how to tackle this post cataract surgery refractive surprise. Very important talk. So I'll be just trying to how to solve this problem. So refractive surprise is the failure to achieve the intended post-operative refractive target. It either can cause anisometropia, or in some patient even it can cause a dominant switch one eye to the other eye. So the what is the benchmark? I think 85% of the eye should be have a refractive surprise within one diopters, or 55% within zero point 0.5 diopters of target spherical equivalent refraction following the surgery. So your biometry has to be dead accurate. So let me come to the prevention. The best way to manage refractive surprise is prevent it. Accurate biometry, A-const optimization. I think still some of our friends still being doing with the the immersion technology. I think you may have to do 2 to 3 readings. Make sure that the proper IOL you will be implanting. And very important is to select the proper intraocular lens formula. And last, in the end, being a surgeon, whatever your assistant gives also, don't try to. Always in my OT, I keep my case sheet open and my assistant has to show me the exact lens, exact A constant and the particular lens power, then only I will implant. So first, once you got already post cataract surgery refractive surprise, now how to identify the cause? First do the refraction, subjective refraction to the patient. Very important, thorough, detailed fundus examination is very, very important. And detailed examination in the sense, see to that whether you have put a tight corneal suture, if the patient referred from the other places. Then look for a placement of the intraocular lens, whether in the sulcus or whether it is subluxated. Because see what happens, when you do with the optical biometry, normally it tend to give in the bank implantation. But you would have put the lens in the sulcus, that itself will get you 0.5 diopters of residual refractive error. So it's very important to implant the lens within the bag. Then sometimes this distended capsular bag might be due to the retained viscoelastic behind the IOL. That is also very, very important. Then always look for any presence of corneal pathology, whether you would have missed that, corneal scarring, whether already post-op patient is having a corneal edema, you need to find out. In the end, I need to, especially patient with a distended bag with the visco behind, normally it gives a myopic shift. So you have to have a very good slit lamp examination afterwards. Later on, if the patient is still having a hyperopic shift, always keep in mind that patient is having a post-operative cystoid macular edema. That time you may have to do the OCTs. So I think review the refractive history as well as the biometry, take out whole the case sheet, what IOL selection process, surgical records. All, once again, major cause, if you ask me, is wrong patient biometry and whatever the you and wrong A constant. See, I had my personal experience. Same lens, hydrophobic lens. I don't want to tell about the company. Same hydrophobic lens, same material, same design. But one lens has been manufactured around 1 year before, has got a different A constant, and other lens has been manufactured after 1 year, which has got a totally different A constant. When you put in the biometry, when you put it in the IOL Master 700, if you put for the both models, suddenly you will see a difference of 1.5 diopter. Suppose if your assistant make that mistake, then you are something you cannot excuse yourself. So always check the axial length by repeating the biometry. Check for abnormal keratometry. All my patients, whenever I do premium surgery, even for monofocal, I do topography. I just want to make clear that the patient doesn't have the undiagnosed keratoconus. If there has been no error, refractive surprise can be attributed to now next is effective lens position. And a similar error may occur in the fellow eye also. You have to be very, very careful. One of the patient always used to have their effective lens position used to change. used to come back to me every time with a one diopter. I used to make a arc, then later on I had a problem. So it is very, very important about the effective lens position. So coming to the management, explain the error openly to the patient. Apology. Apology means it is not you have done the mistake. This is not an declaration guilt what you are telling to the patient, but an acknowledgement that you have not achieved the desired target refraction. Even you can take a second opinion also, that makes patients more believing you. So options. Sometimes if it is very minimal post-refractive, this one surprise happen, very minimal refractive error remaining, doing nothing is the best option. Because many refractive surgery do not require further surgery. Suppose patient there is some amount of myopia remain, they will not grumble you just because of they will have a very good near vision. And some patient might be already wearing spectacles before cataract surgery. If you explain that you are already wearing glass, we are giving the glasses, I think you can continue with that. So correcting this surprise depending upon the comforts of the surgeon, which IOL used, how long it has been, lens has been implanted. Of course, retain viscoelastic. This is the one indication I would like to insist here about the early laser capsulotomy. Around 1 month, still that visco remaining. Then early laser capsulotomy can disperse the viscoelastic and allow the anterior displaced IOL to move posteriorly. Then corneal refractive surgery. Very important, not before 1 to 3 months for small amounts of residual error, or to even can wait. The best option, PRK or LASIK, even those are with the smile also. In terms, I think the results with PRK and LASIK is same. In older patient, PRK is better because of, I think, the dry related complaints. For younger patient, I think you can do LASIK or you can do even with the smile also. So 1 or 2 words about the ablation profile, what you have to go. Best is, I think, wavefront guided treatment that gives a better results than the conventional LASIK. However, some authors are explained, especially Shack-Hartman abramator in eyes with the multifocal IOL. According to the Genrita et al. Evaluated the outcome of wavefront guided treatment with the iris registration after implantation of different multifocal IOLs in 29 eyes of 19 patients. They found good results with the diffractive multifocal IOLs, but not with the refractive IOL. So once again, I am insisting here, go ahead with the wavefront guided treatment with the PRK with a small amount of refractive error. LASIK seems to be safe eyes with the previous YAG capsulotomy. But once if you do a YAG capsulotomy, never ever think about IOL exchange. So always you have to keep YAG capsulotomy in the end. Once if you done the LASIK flap in established, additional optical adjustment can be also performed whenever it is necessary. So there are a lot of limitations even for laser refractive procedure, because see, most of us I think don't have a refractive machine, extra cost, and some patients with a low corneal stromal thickness also you cannot do the LVC. So the other option for is lens based procedure. Either you can go for IOL exchange or piggyback IOL, especially patient with a high degree of spherical error. So very important, do not alter the anterior corneal surface, and also do not change the corneal refractive power. Very, very important whenever you are doing either IOL exchange or with the piggyback IOL. So there is no special setting is required, those who require for laser refractive surgery. So add-on sulcus IOL, I think it has becoming much popular. Lot of patients are coming to us. I think these lenses, these are the piggyback lenses giving a very good results. I think only thing is you need to know exactly. If you ask the company, they will tell you how to inject. You can put it over the previous lenses. Piggyback lenses are less accurate than the laser refractive surgery, but definitely good for high degree of refractive errors. So piggyback lenses, of course, easiest surgery. The only disadvantage always you should, I have come across this complication, patients with a pigmented dispersion. Of course, these piggyback lenses are much expensive than the regular lenses also. You need to think about that. Of course, I have been using this Sulcoplex lens from one of the company from London, no financial interest. But a lot of patients, I think post cataract surgery, they wanted to implant a multifocal lens. I tried with this Sulcoplex multifocal lens. It has given me a tremendous results. In conclusion, LVC laser refractive surgery has been shown a viable, non-invasive and accurate procedure to correct emmetropy after cataract extraction with IOL implantation. Lens-based procedure, IOL exchange or piggyback lens implantation are also possible alternative. Piggyback intraocular lens technically easier, more accurate than IOL exchange. Better indicated cases with extreme emmetropia, corneal abnormalities, or when there is no available of excimer platform. Thank you one and all for